Hello and good evening to you all from a slightly cold and slightly dark Canberra. My name is Stephen Adair. I'm one of the specialists here at IVF Australia Canberra, and I'm currently the clinical director here at our unit, where we have three specialists, myself, David O'Rourke, and Ben Stevens. This evening's presentation, all you need to know about fertility or your fertility family, and there is the opportunity to answer or ask questions through the chat button, and I will do my very best to respond to those as we go along. And if not, I'll certainly return to them before we finish tonight. I thought I would give it a couple of minutes to ensure that anybody who was registered could join, and so I'll start the presentation momentarily. I hope you can all hear me clearly, despite my husky voice. This is the real benefit of social distancing, when the doctor continues to sound a little bit like this. So if you can't fully understand me, I do apologize. So when we talk about fertility and its continuum with pregnancy and live birth, then we are all want to start in the same place and consider not just fertility treatment as medical treatment, but as part of that continuum of pregnancy with pre-pregnancy counselling. We want to consider perhaps coffee intake, although nobody needs to stop. Alcohol, certainly reduce, but everybody needs a glass of wine some days, particularly in front of the Matildas on a Wednesday evening. Consider diet and exercise, a healthy BMI. Too little or too much may affect your fertility, and of course, smoking and any other form of recreational drugs. As fertility specialists, we often see women and couples who attend and ask us why they are not falling pregnant naturally. It is not an uncommon situation where a couple will be trying, and in fact, 15% or 1 in 6 couples in Australia will require some assistance in conceiving. When we look at a couple who have been trying for 6 to 12 months with regular timed intercourse, part of the initial consultation and therefore the investigations are trying to find a cause for that couple's subfertility. That might be a male factor, or it may be a female factor related to either ovulation, often indicated by a regular or irregular menstrual cycle, or to the fallopian tubes. However, in a couple, often the commonest reason is a little bit of both, male and female, perhaps not ovulating every month, or not quite getting timing right, or low-level male subfertility. There are a small group of couples that, despite intensive investigation, we don't actually find a cause. Joe has asked me, what is too little or too much? So a healthy BMI would be between 20 and 25. And 25 to 30 would be by the charts regarded as overweight. I don't think there are many of us are too concerned by a BMI between 25 and 30, but certainly once the BMI is greater than 35, that is a concern. Equally, a BMI below 20 may be associated with irregular cycles as much as a BMI greater than 35. Excuse me. It would be important to try and normalize and moderate lifestyle and diet and exercise. We know that many pregnancies occur outside these, but in fact, if given the opportunity, I think we would all encourage both men and women to look at their general lifestyle, their alcohol intake, and to try and moderate and bring into the middle road these things. So in an initial consultation with a fertility specialist or even with a GP with a special interest in fertility, they will review your medical and fertility history, assess your general health, organize some fertility tests, which we will come back to, and of course, seeing a specialist is best done if you've already seen and got a referral from your GP. Now, one of the common things that we're asked is to talk about the female fertility tests, and is there a test of my fertility? We do know that the ovarian reserve for women falls with advancing age. Men's fertility seems to be maintained despite their age. There is some more recent evidence that male age is important, but less so than perhaps female age. There's two common assessments that we use to assess ovarian reserve or ovarian age. One is an ultrasound test, but the more accepted test now is a blood test looking at the anti-Müllerian hormone level. Unfortunately, that blood test does not get covered by Medicare, and there are some expenses for that. So you can see from this graph that the total ovarian reserve falls by nearly half by birth and by half again towards puberty, and then gently and gradually between puberty and menopause falls down to where the ovarian reserve is negligible and the ovarian function stops. Now, Durga has asked a question about the cost, and I will come to that before I finish tonight, I assure you. So what are some of the potential female factors? Well, we've talked about irregular ovulation or failure of ovulation, which is often associated with polycystic ovarian syndrome. That can lead to prolonged or irregular periods. Equally, there would be concerns regarding the fallopian tubes, which may be damaged due to previous surgery or previous infection, and also other female gynecological issues like endometriosis and fibroids. These are often diagnosed in the fertility workup with either an ultrasound of the pelvis or a laparoscopy, depending on the symptoms. For male factor, tests, we would look at a semen analysis, and you can see from this graph that the semen parameters can change quite significantly over time. And certainly one of the best things for sperm quality is regular and consistent ejaculates. As sperm production falls off, then it can improve sperm quality. Now, just before I continue with male factor, there was a couple of questions. Michelle has asked, my periods are regular, does that mean I'm fertile? What it means likely is that you are ovulating regularly and that your most fertile time will be on about day 14 of a 28-day cycle. And if your cycle is shorter than 28 days, then that fertile time moves to earlier in the month. And if your cycle length is longer at 30 days, then your most fertile time moves later in the month. Tara's asked, can AMH levels change? Yes, they can. They can be altered by other medication, as you described, and from month to month and cycle to, and within a cycle, then yes, you can get different levels. What you seem to describe is a cause for a reduced AMH, but in general, the trends are real. Now, just because your AMH level is low, that does not mean that there is no chance of pregnancy. It just means that it's a very useful marker as far as marking and predicting success. Or if we do follow an IVF process, looking at the drug doses. So as far as male factor fertility, when we look at sperm or semen analysis, we look at numbers, we look at motility, and we look at size and shape. Sperm quality can be affected by genetics. It can be affected by some blockages in the plumbing, or in fact, because there is a lack of sperm production. Clearly, having had this initial panel of investigations, it would be important to follow these and discuss various options. We would recommend the most appropriate treatment, which certainly is not always going straight to IVF. It may be that ovulation induction with cycle monitoring, if we believe that ovulation and timing is an issue. We may believe that if there's minor male factor that we want to consider, that cycle tracking with intrauterine insemination, and all these things can be considered prior to IVF. As well as creating a treatment plan, once you start down a treatment path, we will have you register for our online portal called Precision Fertility, which will provide you with more patient information and more details about your individual treatment plan. So, as I say, some of the initial treatments could be cycle monitoring, ovulation induction using both tablets or injections. Any fertility drug does carry a risk of multiple pregnancy, and so we would always encourage cycle monitoring with hormonal levels and ultrasounds to avoid higher order multiples. Now let me go and just answer a couple of questions. Jane has asked that her partner's had a vasectomy, and so if men have had a vasectomy and wish to have further family, they may consider vasectomy reversal, or they may consider an IVF process using surgically collected sperm. And we can talk about that as we continue through the presentation. Bex has asked if a particular level of AMH is decent, and I would say yes, it is. It's very much in the normal range for that age group, and probably has not changed significantly over the past couple of years. Joe has asked about sperm factors and particularly sperm agglutination. And it may be, Joe, that if we exclude other causes such as infection or other problems for agglutination, then it might be that that sperm is more suitable for something like intrauterine insemination as the sample is prepared and washed. But certainly there are some male fertility multivitamins such as Menavit that may improve sperm quality. So talking about intrauterine insemination, it may be of benefit in the couples that have unexplained infertility. It will be appropriate potentially if there is tubal disease or endometriosis. It is often used in younger couples, and one of the biggest groups we would use it for might be in single women or in women in same-sex relationships that wish to consider the use of donor sperm and would like to achieve a pregnancy without going straight to IVF to begin with. Depending on the cycle nature, it can be with ovulation induction, both tablets and injections, or it may be as part of a natural cycle, and sometimes we will add on some low-dose hormonal stimulation for ovulation or low-dose support for the luteal phase or the second half of the phase with progesterone. So if we choose to go down an ART or an assisted reproductive technology cycle, you will often hear described both IVF and ICSI. So IVF is standard IVF, where we take the sperm, we put it in a dish with the eggs together, and we let the gametes do their own thing. We then assess for fertilization and the creation of an embryo the next morning. IVF ICSI, or intracytoplasmic sperm injection, is the injection of a single sperm into a single egg. That's a lab technique that we don't use routinely and is best in this country and is best reserved for those couples with either a significant male factor subfertility problem or for couples that have been through an IVF cycle and have had very low fertilization rates. Brad has just asked a question about fertility drugs and Clomid. So the use of clomiphene is sometimes used as an adjunct to the FSH injections, although many specialists will just use the FSH injections, and it may be that it's being suggested depending upon previous cycle results. So what is the IVF process? It is long and it can be difficult, and the ups can be marvelous, but the lows can be really very hard. It requires a significant amount of time and monitoring with regular blood tests and ultrasounds done here in the clinic. The stimulation is done by transdermal injection, self-administered. Occasionally, we would use a nasal spray to control the cycle. In more modern cycles, we will use a second injection, so that's 2 injections a day. And that stimulation process goes on between 10 and 14 days. The egg collection at the time that it is ready is done under a anesthetic. It's done under a heavy sedation, so it's not a general anesthetic. So the women who come into a hospital and are monitored by an anaesthetist are still breathing for themselves, but they do not remember anything and do not feel any pain. Currently in Canberra, we are not yet using day local anesthetic. Excuse me, but that may change in the future. We collect the sperm sample, and depending on the cycle type, we either perform IVF or ICSI, and the embryos that we create are kept safe in a machine called an embryoscope, which keeps them in a constant temperature, pH, light environment for 5 days. So we now have the ability to watch and grade and monitor their progress from day 1 through to day 5 with digital real-time photography, which means that they don't need to be moved or disturbed for those 5 days. If the plan is to do an embryo transfer, then that is done on day 5, when we hope to see some mature blastocysts. And if the plan is to then freeze all embryos, they will be frozen at that point. And if we have transferred an embryo, residual good quality embryos will be frozen. And the simple answer to the question asked is that our standard practice is to transfer a single embryo each time rather than multiple embryo transfers to significantly increase the risk of multiple pregnancy. This is just a slide showing some images of embryo development. So day 1, where you see the 2 cells, and then across the days, cells divide, 4 and 8, 16, 32, and then the compacting to form a blastocyst, and then as it progresses to see the blastocyst that is hatching. So when we aim for day 5, this is the stage, and this is what we want the embryo to look like. It's compacted down, and there's an inner cell mass. If the reason for seeking fertility assistance is fertility preservation and egg freezing, then it is a similar process right up until the eggs are collected. And then the individual oocytes are frozen at that point, rather than trying to achieve fertilization and the creation of embryos. So the process, as I've described initially with IVF ICSI is the same process with the stimulation and monitoring for egg collecting and freezing. It should always be remembered that the age-related success rates in IVF do fall if we then use frozen thawed eggs, as they are single cells and don't survive that process as well. as either frozen embryos or frozen sperm. This slide shows a little pictorial reality in what may happen during a cycle. Unfortunately, prior to egg collection, if there are 10 or 11 follicles, that will not mean that we will collect 10 or 11 eggs. It may be that we only collect 9 eggs. And it may also be that of those collected, that they are not all mature. And it may be that they don't all fertilize. And it may be that they don't all reach blastocyst. So that by the time we get to day 5, it may be that we only have 1 or 2 embryos for transfer or for freezing. And this really is about the expectation setting and reality of human fertility, and that we as a species are not very good, and that every time an egg and a sperm meet together, they do not create an ongoing pregnancy. And so that very clearly, this is about setting that statistical expectation. An embryo transfer is done here in the clinic. It is essentially like a pap smear. However, just to make it more challenging, we encourage the women to come with a full bladder so that we can do it under ultrasound guidance and help show the embryo as it is transferred. But it's a simple procedure similar to a pap smear. Any remaining embryos, or if the decision has been not to do a fresh transfer, then the embryos are frozen, and we use a vitrification process that is essentially dehydrating the embryo as part of the freezing process. And it is this development across the last 5 to 10 years that has significantly improved outcomes and success rates from frozen embryos. And although we don't recommend freeze all for everyone, certainly there are some parts of the world and even some parts of the country that would support that as a treatment. But in most practice, if there is a good quality day 5 blastocyst, and the woman feels well, and her hormone levels are good, and her endometrial thickness is good, then we would progress with fresh transfer currently. You will always have ongoing support and monitoring after any procedure. With a blood tests looking not only for progesterone level perhaps at a week, but also looking for a pregnancy blood test after 10 to 14 days. The nursing team and the nurses themselves are phenomenally well experienced and very supportive and available to help answer questions and queries regarding treatment and medication. So some of the advanced technologies that we are using is in the development of AI, and this is being used to try and find the best egg, the best sperm, certainly the best embryo, to really aim for the very best chance of pregnancy and a healthy baby. The embryoscope, and we will come back to genetic diagnostics, but the use of AI is becoming increasingly clear that it will add to the human factor in the support and the selection of the gametes as prior to embryo creation or embryo transfer. So I just want to spend a little bit of time talking about some of the donor programs. That I know this may not be relevant to all, but just this is some of the work that we do here, and we have a very strong history of supporting both single women or men and those in a same-sex relationship to consider fertility and family with the use of either donor sperm, donor eggs, donor embryos, and surrogacy. And there's a lot of work going on locally with ACT Health as they look to revamp and remodernize their legislation around these matters. So we do have a donor sperm registry. This is available to couples with male infertility, to single women, and those in same-sex relationships. You can choose either known or de-identified sperm. However, there are some very clear rules around access to donor information when the donor-conceived child reaches the age of adulthood. All donors will, processed through the clinic, undergo both medical assessment, genetic screening, blood screening for blood-borne viruses, and we're particularly concerned about hepatitis C. And so all donor sperm is quarantined for a minimum of 3 to 6 months prior to its usage. In Australia, there is no payment for human tissue, and that includes both donor sperm and donor eggs. And so the donor numbers available can be less than the demand requires. So there are quite significant wait times. What we're lucky for in IVF Australia Canberra is that we have some very strong connections with some of the overseas sperm banks, and our donor team, both nationally from Sydney and particularly here in Canberra through Michelle and Amanda, will help you understand those donor choices. And donor sperm can be used both with insemination cycles and with ART cycles, IVF and ICSI. Equally, if a couple in a same-sex relationship comes and one couple wishes to have the stimulation and the other couple wishes to carry the pregnancy, then that form of egg and embryo sharing is accepted and possible here in Canberra. We mentioned briefly about fertility preservation and egg freezing. Clearly, there is a lot written about social fertility and about social fertility preservation. There are, however, some male and females who come to the clinic who require fertility preservation based upon medical reasons. That can be largely because of cancer and prior to either surgery or oncological treatment. And we will do our very best to see these folk as quickly as possible to talk through those options prior to their treatment. Equally, some men will consider fertility preservation, particularly if they are in the forces, before going overseas, and for women knowing that their fertility falls with advancing age, then they will request egg collection and egg freezing. To maximize their future pregnancy rate, they do, however, need a significant number of eggs. And so it may be that they require the process to happen more than once to maximize their future success. So this is a little bit from IVF Australia about the success rates following fresh embryo transfer. And really, I think that the lines that we're interested in should be the green lines, the live birth rates. And I suppose if we turn this graph through 90 degrees, it is clear that as the age increases, the live birth rate falls significantly, and particularly over 40. In some numbers, somewhere about 35+%, below 35, and less than 5% in mid-40s. So it is significant. And I think that any of the specialists that you may talk to will ensure that that understanding is there. Equally, some women that we have seen will say, well, particularly if I'm single, I have no chance. So 5% is a success rate I would like to go towards understanding that it is unlikely. These are the numbers as described from frozen embryo transfer. And as I've said, it's clear now that these are improving significantly. So I suppose a very fair question for those of you that are watching this evening will be, why would I choose IVF Australia? Here in Canberra, the Canberra Fertility Clinic was the first fertility clinic in Canberra, which was opened in 1987. And that then became part of IVF Australia, which was one of the first fertility services in Sydney back in '86. And we are now also part of Virtus Health, that has both fertility clinics and day hospitals, not only across all Australia, but now internationally as well. And we've recently opened a new clinic in Denmark, in Copenhagen. And I think that shared knowledge and experience helps us drive change and progress within this field of medicine. We do offer a full range of treatment, including genetic pre-implantation, genetic diagnostics, pre-pregnancy, the NIPT. So there's a variety of supports by the diagnostic arm of fertility. So I've tried to answer a number of the questions as we've gone along. One of the questions that I was asked is, when should I seek help from my GP and when should I be referred to a fertility specialist? I think if you're in if I separate away either the single women or the women in a same-sex relationship that require donor sperm, I think if you are a couple who has been having regular timed intercourse with regular periods for 12 months without success, then I think that's probably the time to seek opinion. I think if you have a woman with an underlying gynecological issue and you're concerned about the irregularity of periods, then it may be that between 6 and 12 months feels like a more appropriate time. Diana has asked me about women with polycystic ovarian syndrome and what are the numbers. I think, Diana, to that, probably it depends on how well, when we attempt ovulation induction, either with tablets or with low dose FSH, we see a response. In Australia, we are not constrained by strict rules as far as the numbers of each type of treatment we need to consider prior to escalating the treatment. And I think that most women here would do somewhere between 3 and 6 cycles of ovulation induction, with or without insemination, depending on their circumstances, before they would escalate to IVF. But I think it's a multifactorial answer given age and other considerations. But yet many women will not need or wish to escalate to IVF and once they have achieved ovulation and correct timing of intercourse. Katie's asked me about the role of genetics and if there's a family history of genetics. That should be ascertained in the history, and if there is any concerns, then it may be that we will do some baseline genetic testing for both parts of the couple, and then consider referral to our genetics team to consider and discuss the pros and cons of pre-implantation genetic testing as part of an ART cycle. So Bex has asked me a question that about unsuccessful cycles and the pros and cons of genetic testing. I think the answer to that, Bex, is that I think having a discussion around embryo testing is important at this time. I think that in the past, we really believed that PGT was going to change forever the total success rates. I think what it has done is certainly prevent women going through unnecessary transfers, and it's increased the success rate per transfer rather than the overall success rate. Because, of course, you won't transfer an embryo that you know is never deemed to achieve a pregnancy. However, the process of testing, 1 in 10 of the embryos will not survive that process. So there are some negatives to those positives. But either myself or any of my colleagues are going to be more than happy to talk through that with you. And it may be that at your own clinic, that they're also able to talk that through with you. Diana's asked me a question. So as far as donor sperm, there's both local New South Wales and ACT, and then access to overseas. Every state and territory, unfortunately, has got different rules. In the ACT here in Canberra, we have access to both the American Sperm Bank currently through the World Egg and Sperm Bank, and through the European Sperm Bank. We did used to work with a company called Zytec, and hopefully that will return soon. If you want some information around donor choices, then the donor team here at the clinic can provide you with some further background information which will then give you some access to the donor profiles and the choices that are available there. And as far as frozen embryos, yes, embryos are always transferred in what we would regard their greatest likelihood of success, because what we want is to achieve pregnancy, and we firmly believe that the best chance of pregnancy is through the best quality embryos. As far as PCOS, then I would say that it can be treated. We can improve ovulation, and we can try and increase the fertility likelihood based upon the treatments available, including medical treatment and lifestyle treatment. But the hormonal disproportion with it can be managed. I'm not sure that it can be completely resolved. And in case there is any concern regarding anything about irregular periods, essentially we use a regular period or as a marker of regular ovulation, and therefore improving the likelihood of achieving pregnancy with timed intercourse. But an irregular cycle does not necessarily mean that it's infertile. It's subfertility because it reduces the opportunity month on month. But these are reversible causes, often using either oral or injection ovulation induction. Joe has asked about surrogacy. I think, Joe, that surrogacy is possible. It's clearly a major process and discussion, both ethically and legally. But yes, through the IVFA, we can have a discussion around surrogacy. And somebody has asked me about immune protocols. Immune protocols are becoming more common. I think the evidence is still undecided, and I think that each and every specialist will be open and prepared to discuss these matters as they work through your history and your fertility journey. And if it is not possible to do some of the high-level immunoglobulin protocols here in Canberra, then we can certainly work with some of the specialists in Sydney who are more experienced and supportive of such treatments. So I hope that I have been able to provide you all with some additional information and answer as openly and frankly as I can the questions that you've asked me this evening. I know that myself and my colleagues here will be happy to assist, and through the clinic here in Canberra and with our colleagues across New South Wales with IVF Australia and beyond into Queensland or Victoria or Tasmania through Virtus Health, and internationally through Virtus Health, support you through your fertility journey. So I'd like to thank you all very much indeed for joining me this evening, and wish you a safe weekend. And for those of you with any joys, I guess we will look forward to Sunday night and answer and cheer on the Lionesses despite the Matilda's absence. So take care and all the very best indeed. Good night.